Welcome back, everybody. Welcome back to this engagement hearing for Fit for the Future. Just because we might have new people watching online, we'll just do some reintroductions of the panel here before we introduce our colleagues from REACH, and they can introduce themselves in a second. So if I just quickly run around the table. Mark, would you like to?
Good afternoon, I'm Mark Pietroni. I'm the Medical Director and Director for Safety at the hospitals. I'm also a consultant acute physician.
Good afternoon, I'm Julie Clapworthy. I'm independent nurse on the governing body at Gloucestershire Clinical Commissioning Group.
Good afternoon, Simon Lansley, Director of Strategy at Gloucestershire Hospitals.
Good afternoon, I'm Amjad Uppal, Medical Director in Gloucestershire Health and Care, and I'm a Consultant General Psychiatrist.
Afternoon, Jeremy Welch. I'm a GP in Tewkesbury and I work for the Clinical Commissioning Group in the Urgent Care team.
I'm Nicholas Duffin, who's the independent chair today. I'm from the Consultation Institute, of which I'm a fellow.
Afternoon, I'm Rob Stacey. I'm an emergency medicine consultant in Cheltenham and Gloucester.
Good afternoon, I'm Eve Oliphant. I'm the Divisional Director for Nursing and Quality at the Hospitals Trust, and I'm also the Specialty Director for Cardiology and Respiratory Services.
Good afternoon, I'm Cathy Campbell. I'm Service Director for Urgent Care in Gloucestershire Health and Care.
Hello, my name is Maria Medrow and I'm Senior Nurse in Gloucestershire CCG for Urgent and Emergency Care.
Okay. And our colleagues here from REACH, perhaps you'd be good enough to introduce yourselves for the panel, if that's okay.
Thank you. I'm Michael Ratcliffe, the Chair of REACH.
Okay.
I'm Tony Goodman. I'm a recently retired consultant GI surgeon.
Okay.
Worked for the Trust for 27 years.
Sorry, guys, you might want to use the speaker, I think, so that anybody watching can pick it up. I think you've got a couple there. It should be on, I think, already. Yep. If I could just ask you to use them, yeah, if that's all right, yeah.
Hi, I'm Tony Goodman. I'm a recently retired consultant GI surgeon. Worked for the Trust for 27 years.
Okay.
And I'm Michael Ratcliffe, the Chair of REACH.
Okay.
I'm Chris Hickey. I'm a local businessman and I'm the spokesperson for REACH.
Good afternoon, I'm Julius Marstrand. I'm a local campaigner for NHS Services, but was a governor of the Hospital Trust for 7.5 years.
Okay, all right. So gentlemen, you know the format for what we've been doing today. You have an opportunity to say anything that you basically want the panel to listen to or take into consideration as part of a process in formulating solutions under Fit for the Future. And then when you finish talking and expressing what you want to, what they will do is they will broaden that discussion and talk to you about elements of what you've discussed or what you've brought up, ask you questions for any clarity, that sort of thing. So we can have a proper discussion on it, if that's okay.
Thank you, Nicholas.
All right. So feel free to sort of proceed as you want to.
Thank you, Nicholas. I'll start, if I may. Little history about REACH. The REACH was set up in 2013, led by the Cheltenham Chamber of Commerce, because of its concern in the reduction of overnight facilities at CGH in 2013, July 2013. It is supported by local businesses, circa some 10,000 employees in Cheltenham. It's supported by local residents, and in that context, we have some nearly 90 parishes in the north and the east of Gloucestershire, and 76% of those parishes who've responded all have asked and wished to see a full 24-hour A&E Type 1 facility in Cheltenham. We have had recently 25,000 signatories to 2 petitions run by both political parties in Cheltenham opposing the closure of the A&E Type 1 facility. REACH itself, who has done a survey, has had several thousand responses to date, of which 95% of those responses are against the closure or the reduction of the A&E facilities in Cheltenham. And on our social media feed, we've had over 35,000 engagements to date. Substantial. I think you will all agree, substantial numbers of people real evidence of real people opposing the Trust's plan. And so we are talking of somewhere between 200 and 250,000 people. That is more than a third of the population of Gloucestershire who oppose the reduction of services at Cheltenham General Hospital and wish to see the reinstatement of the 24/7 facilities, which existed prior to July 2013. So, what does REACH support? We support the development of health services for the whole of Gloucestershire. We support proposals which would see centres of excellence across the county, including the MIU Type 3 units. We support plans to deliver first-class emergency care for both county hospitals. We support plans to deliver a centre of excellence specialising in planned and cancer treatment. And we support plans to continue and develop sustainable full Type 1 emergency departments in Cheltenham and Gloucester. I think we would like to initially address elective surgery, so I will ask Tony to comment on those points. Thank you.
Thank you. Over the last 27 years that I was a consultant general surgeon within the Trust, the role underwent steady evolution towards subspecialisation. My emergency surgical role also changed similarly, and now the surgical consultant who leads the emergency team is either an upper or a lower gastrointestinal surgeon. This is not just a local trend, this is a national trend, as the vast majority of general surgical emergencies are encompassed by these two specialities. This process of subspecialisation requires extended teamwork between different specialities to ensure the delivery of a good quality, safe and coordinated surgical service, both in the emergency and the elective environment. This team working is essential, requiring close clinical linkages between allied surgical and medical specialities. We've got a diagram, a Venn diagram, that you'll all receive at the end, but I'll just go through the main parts of it. In the middle of the Venn diagram, you've got upper GI and lower GI surgery. But this interlinks, obviously, very heavily with medical gastroenterology. But the surgical part of the service is inextricably linked with our other surgical colleagues, the oncogynecologists, the urologists, and the vascular surgeons. And very much the cancer centre, which is mainly based in Cheltenham and is a very heavy user of all of these services. And obviously we're also collectively a very heavy user of critical care, nutritional support, imaging, specialist nurses, links to the community, all of the other things that make the service work really smoothly. I've got a couple of real stories, patients who have been anonymised, that sort of illustrate some of these points. First one is a 43-year-old lady who had severe bowel inflammation, had a chronic inflammatory bowel disease. She needs both elements of medical gastroenterology and surgical gastroenterology and a lot of complex support from stoma care sisters and nutritional support. And her planned care involves a lower GI surgeon to remove her colon, a medical gastroenterologist to monitor her complex drug treatments and make sure that they all occur at the right time and their relationship to any other surgical intervention is appropriately timed. The nutrition team which for inflammatory bowel sufferers is absolutely key to their well-being and their health. When these patients undergo surgery, it's major surgery, and we almost nearly always require the assistance of our critical care team to support us. When they're on the GI surgical ward, they're surrounded by very well-trained specialist ward nurses who have got all the necessary skills to notice if there's a problem and who to let know when that problem occurs. And it's only possible to deliver this sort of care in a coordinated team spirit. We're not a group of individuals, we work as a coordinated team. Another real story, a very unfortunate 35-year-old man who presented with advanced bowel cancer. After all his complex imaging and other investigations, it showed that although his cancer was very locally advanced, it was potentially curable by combined surgery. So once again, because of the nature of the extended team that we're involved with, a lower GI surgeon removed his colon that was involved with the cancer. A consultant urologist removed the kidney that was obstructed and involved by the cancer. A vascular surgeon was there to deal with the major blood vessels that were involved. An upper GI surgeon was also available to us if we needed them, if there was involvement involving the upper abdomen, stomach, pancreas, spleen, diaphragm, all of the things that can happen in this disease. Obviously, this patient left theatre, went straight to critical care, and afterwards, when they returned to the GI ward, once again, they were assisted by all the specialist ward care team. And all of this is only possible if you have a coordinated team of people who are available to you at the right time without unnecessary delay. So Gloucestershire Hospitals NHS Foundation Trust is one of the largest in the UK, and it's based around 2 major district general hospitals supported by several important peripheral units. To use these facilities to their best advantage and to serve the people of Gloucestershire requires a balanced approach based around 2 vibrant, well-staffed, well-equipped surgical hubs. We are told that the Trust's preferred long-term plan for both elective and emergency general surgery, according to that stated by its CEO to the sitting MPs and council politicians, is to have 2 hubs, one mainly elective and the other mainly emergency. This view is supported by the NHS England, by Get It Right First Time, which is one of the departments within the NHS, and the Royal Colleges. All of these national bodies state that a geographical separation of the 2 hubs is the more efficient way of dealing with the combined general surgical workload. This is especially true with regard to bed usage, so that the seasonal fluctuations in emergency admissions that we're all aware of do not cause frequent distressing cancellations of major elective surgery. In Gloucestershire, if the Trust follows this national advice, it would result in 2 vibrant major hospitals, both with a resident general surgical presence, continuing to develop multidisciplinary teams able to cope with modern, complex, elective and emergency surgery, as described as centres of excellence. Thank you.
Okay.
Thank you very much. So that's a presentation on general surgery. The question before we start on the second part of our presentation today, which is around accident and emergency care, I think we need to ask a question to clear up something that requires clarification after the Secretary of State's statement yesterday, because in the aftermath of that, it's clear that people reading it on our Facebook feed and the response that we've had indicate that they believe the Secretary of State has ensured that a Type 1 A&E facility will remain at Cheltenham General Hospital. It's also clear from the Trust that the Trust believes that the Secretary of State is supporting their proposals, which are to downgrade the Type 1 A&E and replace it with a Type 3 A&E. So the Trust will be able to claim that an A and E is open in Cheltenham, but it is not an A&E that anybody sitting behind me would understand or recognise. It's not an A&E that the Secretary of State would recognise. It's not an A&E that anyone on this side of the room, looking at yourselves, would describe as an A&E, an urgent treatment centre or a minor injuries unit or any other category of urgent or emergency treatment which falls short of a facility that can receive blue light ambulances for the most severely and critically ill emergency cases in Cheltenham is what we mean by an A&E, and we are confident, having had extensive conversations with our MP, that this is the Secretary of State's understanding that what was promised to him yesterday is that a Type 1 will remain. So if we can get that reassurance from you, and if you can agree that that is what has been agreed with the Secretary of State, then that obviously will determine what the next part of our presentation will be.
The panel that you've got in front of you now can't give you that reassurance because it's not a decision-making panel. It's here to listen to evidence of what you think should be considered in solutions and what the format of the Fit for the Future solutions for healthcare services should be. But that question can be passed on and you can get an answer.
The Trust management are here. It's a very simple question. I don't want to waste your time or our time or anybody's time, because if, as appears to be from the Secretary of State's understanding, that a Type 1 A&E is going to be retained in Cheltenham, that substantially affects what we have to say, because clearly, as we outlined at the beginning of the presentation, that is our goal and aim. And if we've achieved our goal and aim, which many people, in response to what the Secretary of State said yesterday, many people in Cheltenham believe that that is what the Secretary of State said and believe that he meant a Type 1 A&E. However, as you know, in our conversations and discussions between REACH and the board and the Trust, there is a very serious gap which results in essence, a dialogue of the deaf. The Trust's position is, and always has been, we have no plans to close A&E at Cheltenham. Now, this is an interesting use of words, because what their plans are, as stated in Fit for the Future, are to downgrade A&E and replace the Type 1 A&E that we have now with some other facility which is not going to be consultant-led, which is not going to be blue light, which is not going to be capable of receiving that. And the document very clearly states that that facility and that resource will be, as intended to be, in Gloucester. Now, the Secretary of State, following representations from the MP, has made a commitment, following a telephone conversation with the Chief Executive, that a Type 1 A&E will not be closed. Trust management are here. It's a simple question. It helps us. It will help you. It will help this public engagement if that point is cleared. I appreciate that the group of people sat directly in front of me can't. There are other people in this room who can answer that question.
As you're aware, that when this event was agreed and designed, nobody was predicting the events of yesterday, and that your part in this particular event was designed to provide what you thought that those who are designing solutions should be thinking about prior to yesterday's event. That's the way this event has been conducted all day, and there's been other people, of course, who have referenced yesterday's events. So we'd like to continue in the same vein, because if you let me finish, the people who've preceded you have proceeded under that basis, and you're now you'll be changing the rules effectively here in the way in which this event is being conducted, which is unfair to the opportunities that were given to people earlier. So I would ask you, if you could, to continue in the vein of what you want considered, and I'm sure that separately to this event, that the Trust will be happy to talk to you about the interpretation of yesterday.
We certainly do not want to change the rules. I'm sorry if that's the impression that you've got from us. We do not want to change the rules under any circumstances. We're asking for clarification. There are people in this room who can give that clarification. It is very clear that, as all of us, we were caught completely on the hop. We did not realise or know or appreciate or understand that the Secretary of State was going to do what he did yesterday. It will help us substantially, ourselves on this side of the table and you on that side of the table, if that point can be clarified. Because if we clarify that point, what we're going to say would be quite substantially different than if the point isn't clarified. So it is, I think, a fairly simple request, because it's a simple question that requires a simple yes, no, or maybe. And there are people in this room who can give that answer, yes, no, or maybe.
I'd be more than happy for you to have that conversation outside of this room with those people if you wish to do so. But with regards to what we're doing now, the position that I was actually provided with regards to A&E at Cheltenham was that no decisions had been made, and what they wanted to hear from the people contributing ideally, and the panel is asked to actually explore that with you, is what the model should look like. So in theory, it shouldn't make any difference to what you would want to say.
Chair, may I ask for a small adjournment, please, for no more than 5 minutes, whilst I talk to my fellow colleagues?
Yes, by all means, yes. Yeah, of course. Yeah. For the benefit of anybody watching online, we're going to go offline for the next 5 minutes and just take a short break, and then we'll be back with you. Thank you. Okay, welcome back, everybody, and the gentleman from Reach, thank you for taking that short time out. Would we like to resume?
Thank you, Chair. We would like to take up your offer, Chair, and if you could confirm that the Trust would be prepared to meet us after this conference, we would be pleased to go forward.
Okay, I think that I've had a quick word afterwards, and certainly happy to have a conversation afterwards, but I'm not sure that's going to be able to happen immediately afterwards. And you have got channels open already. So are you happy to pursue the channels that you've already got open?
Could we please clarify, if it's not possible to take place immediately after this hearing, when it would take place?
Yeah, I think that the problem I've got is that you're putting me in the position at the moment of trying to commit to something that I'm not briefed on.
Chair.
So
your offer, Chair?
Yeah, that you can have a conversation outside of the remit of what we're doing here. Yes, but I can't commit to making an appointment as such, can I? I'm not.
Well, Chair, with great respect, you have the relevant people in the room.
Yeah. And I'm here for a specific purpose, not to act as specifically a liaison between you and the Trust. I'm here to actually make sure that the people who are on this group of people listen to the rationales and what you feel needs to be done.
Okay, Chair, thank you. Appreciate your comments. On the basis... Sorry,
Chair,
apologies.
Chair, can I just suggest, because clearly there's the risk of an elephant in the room, and that being me, and I don't want to in any way make this more difficult and to appear any less helpful than I can be. I think what the Chair alluded to is that we have been in a dialogue, both in respect to through correspondence but also through meetings. We have a meeting scheduled again, or certainly trying to firm up a meeting. We've got a provisional date. I'd be very happy to continue the dialogue through that established meeting. If it would be helpful to try to bring that meeting forward, because the meeting involves others beside myself, then I'd be really happy to look at that too. I'm not able to stay on today for a further conversation, but as we've demonstrated, it's a conversation with the system, not with an individual. These are decisions not being made by one body. We're here today as One Gloucestershire, so we'll take some time to arrange, but I hope we'll be able to do it in a way that feels timely for you.
Thank you very much. The question really relates to a conversation between yourself and the Secretary of State. We don't need anyone other than yourself. You are in a position to say what you said to the Secretary of State. You're in a position to confirm that. The Director of Strategy. It's a fairly simple issue or question that is really a matter of fact. And I think from our point of view, it is something that a further adjournment for 5 minutes would clarify, because it doesn't require a meeting. It requires clarification of the conversation yesterday and what you meant in the conversation and what the Secretary of State understood from that conversation, because we've had that half of the conversation, not directly from the Secretary of State, but certainly from the MP concerned. So I don't want to prolong this any longer than it's necessary. It is a short matter because it's in essence a matter of fact. It's not anything that requires longer negotiation, conversation. It doesn't require referral anywhere else, because either a Type 1 A&E has been promised or it hasn't. And if it hasn't, and if the simple question is, I didn't promise a Type 1 A&E, you don't have to say what you did promise, but you say, I haven't promised a Type 1 A&E, well then that helps us very much in terms of proceeding, because if you haven't, you haven't. There
Okay.
you are.
But
he thinks you have.
Nevertheless, that it's not a conversation for this room and for what we're dealing with now. And there's no reason why there's a public expectation for a private conversation between parties of that sort to actually be part of the conversation here. I would add that this hearing is due to finish at 5 o'clock, that we have other parties coming in at 4:15 who are already here and waiting and expecting to take their opportunity. You do have 15 minutes left to put across what you think needs to be considered to the panel. Any further delays and you're already losing that opportunity.
Yeah, we do appreciate that. We're making the point, and the chairman explained to you that we are sitting on top of a very, very, very substantial pyramid, evidence pyramid of people who are here, and they are expecting us to represent a very clear point of view. And we have stated a very clear point of view that what we are expecting and requesting and here to campaign for is the retention at a minimum of the existing Type 1 A&E at Cheltenham, and preferably that it is restored to its full 24-hour solution. You are clinicians, you know and understand that exactly. We don't need to explain that to you. But for the people who are watching, for the people who are listening, who may have been substantially misled by the conversations yesterday, it is very clear, A, that we state our point of view. We are talking about, to you, the clinicians involved and engaged, and we'll continue our conversation discussions with the Trust, that we couldn't be clearer. We have 25 slides. I'll leave them with you. You can read them and you can read, mark, and inwardly digest those comments. But it is absolutely essential that in this public forum, you understand that although there are 4 people sitting here, there are 250,000 people outside who understand what A&E means. And A&E does not mean an urgent treatment centre. A&E does not mean a minor injuries unit. A&E means a substantially staffed hospital by consultants who are capable of dealing with the most serious emergencies, not all, we understand, the most serious emergencies that occur to people in Cheltenham and in the district in that life. We really don't need to say any more than that, and we don't need to take up any more time, because we can leave with you everything that we would say, which are our arguments, which we have made over a number of periods of time. But you really do need to understand how important it is. And we will continue our campaign until the Trust either comes clean about its real plans, which are to downgrade Cheltenham A&E and replace it with a UTC or MIU, which is actually what the Trust is actually planning to do, and stop these farcical conversations with people, or it says, we recognise and realise that although that was our intention, we have reflected and thought and recognise that for the people of Cheltenham, for the people of the eastern half of Gloucestershire, the facility and the resource that they expect as a minimum in a town of 110,000 people, serving a population of 250,000, dealing with over 500,000 visitors who come every year to Cheltenham, that an A&E of that kind and that size and that resource and that facility and that ability exists. People in Cheltenham do not want to end up going to Warwick or Bristol or Swindon or anywhere else, because the only A&E that is available in the county, which is already jam-packed practically half the time anyway, which will be even more crowded as a result of these proposals, will represent anything other than a near disaster for people in Cheltenham. So we don't need to say any more. We have said everything that we need to say. We'll leave you with our documents, and we will leave this meeting with the understanding that the Trust may have misled the Secretary of State. And if the Trust want to meet us before the 25th of November, our doors are open, and we will meet with them. And I cannot tell you how disappointed I am that a simple question that could be simply answered in 5 seconds has resulted in this more meaningless, shifting, cavilling, squirming and squiggling, which demeans the profession. So thank you very much. We're leaving.
Thank you very much. Okay, thank you very much. Yeah.
Thank you very much, Sophie. Thank you.
Thank you.
Okay, thank you. Right. Okay. Right, so obviously that's opened up a small amount of space. We've got 5 minutes. I don't know if anybody wanted to do anything before we finish with our last session today with John and Mary Thurston, Friends of Lydney, if there's anything. If not, John and Mary, you're more than welcome to come up and talk to us. Hopefully we can have a conversation.
Okay, thanks very much.